Can you start the recording, please? All right, thanks. And next slide. So welcome to our third meeting of the Cost Growth Target Technical Advisory Committee. Feels hard to believe that it's only been a couple of months, but we've made a lot of progress and looking forward to continuing our conversation in the weeds of the data specifications with you all today. Just quick housekeeping, we are recording the meeting. We'll post the recording on our webpage. We'll also have a written summary of the meeting that we will share later on. We have turned off the chat function in Zoom, but you can ask questions to staff if there are any logistic issues. And it really helps us if you list your first and last name and your organization in your Zoom name, just helps with the facilitation and tracking. So thank you all for that. And next slide, please. All right, a quick review of our agenda today. We're going to do introductions. We'll talk about the March 24th meeting summary, where we landed, and some of the outstanding questions that OHA took back to work on internally. And then we'll spend the bulk of our meeting talking about the data submission template, or the data submission specifications rather, and we have some outstanding questions that we're hoping to get your feedback on. We also shared the updated draft of the temporary rules, the Oregon administrative rules that will govern data submission. I wasn't planning on talking through any of that in detail today on the agenda, but we do have those available for you, and we'll be asking for feedback over email if you have any additional questions or comments about the temporary rule draft. All right. Let's go into introductions. I'm thinking now that we have more and more participants each month, it will be easier to switch to do this in a little bit of a roll call fashion instead of me trying to track everyone who's on the meeting. So I'm going to run down the list. It's organized by payer, and then we'll get other non-payer participants at the end. So do we have anyone from Advanced Health?
Morning, everyone. This is Chris Hogan from Advanced Health.
Hey, Chris. And do we have anyone from All Care? Anthem, Atrio, Care Oregon.
Hi, Terry Heading from Care Oregon.
Hey, Terry. Cascade Health Alliance. Cigna.
Hi, Jason Loftus from Cigna.
Hey, Jason. Companion. CVS.
Hi, Tracy Cole
Tracy.
and
Hi,
Kathy
John
Therian.
I heard Tracy and Kathy. Who else?
Sorry, it was John Novickus.
Hey, John. All right, First Health. Healthcare Service Corp. HealthNet. HealthShare. Humana. Kaiser.
Hi, this is Keith Cronin from Kaiser Permanente.
Hi, Keith. Legacy.
Good morning, Sarah. Daniel Porter.
Daniel. Moda.
Hi, Bill Dwyer from Moda.
Bill, welcome. I think we have Medicaid fee-for-service. Chris, are you on?
Yeah, this is Chris Kuhn.
Thanks. Pacific Source.
Hi, this is Jeanette Sims. I have Anna Sue Rincon and Kyle Harada on the call with me from Pacific Source.
Great, welcome. Providence.
Good morning, this is Drew Tarab.
Hey, Drew. Regents.
Good morning, this is Diane David.
Hi, Diane.
Good morning, this is Jared Collins.
Hi, Jared. All right, Samaritan.
Good morning, this is Bill Bushka.
Bill. Trillium.
This is Michael Sutherland. I guess I'm on here for both HealthNet and Trillium.
Great.
Hi, and this is Stephanie Reckner, also here for Trillium.
Great. Hi, Stephanie.
Hi, this is Sean Cratch, also from Trillium.
Great. All right, Umpqua. And United.
Good morning. This is Anna Morales with United.
Great. Yamhill.
Good morning. This is Larry Soderberg with YCCO.
Hi, Larry.
Hi, it's Alicia DeJesus from Aetna.
Great. Hi. All right. Are there folks on the call that I missed?
Hello, this is Wade Penner, joined from Samaritan.
Samaritan. Hey, Wade.
Hi, Cable Hogue from the Oregon Health Insurance Marketplace.
All right. Great. Welcome, everyone. Thanks for going through that. Really helpful to know who we have on the line. And so glad that you are all participating. Okay, let's go ahead to our March 24th meeting summary. Next slide, please, Michelle. And probably 2 more slides. Yeah, there we go. Okay, so we sent out a written summary of the March meeting, but I wanted to just highlight the decisions that we made at our last meeting and just state everything in one place. So we are not going to include out-of-state residents who receive care from Oregon providers. We will include student health plans, and we will remove the no negative number requirement from the template. That was related to the submission template and specifications. Also, we talked about the draft rules. We will use the all payroll claims data methodology to identify the mandatory reporters, and we will not require test data files. Are there any questions or clarifications about those decisions from March? Great, you're making it really easy for me so far. Let's go to the next slide. So there were lots of outstanding questions from March, but there were 2 that we wanted to come back to today. And the first was what to do about short-term health plans. Next slide, please. So we asked whether or not we should include or exclude short-term medical plans, as they do offer a comprehensive medical benefit, but less than a full year of coverage. We thought that it made sense to include short-term health plans. That felt like a decision, clear cut, and that we would look at cost sharing and reporting trends for short-term health plans because that would be important considerations to weave in. However, next slide, then we looked at the data from DCBS. This is the Q4 2020 enrollment report, and none of the carriers that are offering short-term medical plans, according to DCBS, appear to meet the threshold for data submission. So everyone is below 1,000 covered lives. And you can see the plans here on this slide. These 5 plans, or these 5 carriers, would also not be submitting for any other lines of business. So next slide. In March, when we were talking about this, it sounded like some of the carriers did offer short-term plans, but we didn't see that held up in the DCBS data. So I just wanted to bring that conversation back and confirm, are any of you carriers offering short-term medical plans? And are we talking, potentially, are we conflating different plan types in this conversation? So if you remember last month and you said, yes, we have short-term plans, yes, we offer that. Can you maybe share a little bit about what actually that was, and was that truly short-term health plan, or was that something else? And I'm not going to pick on people officially, but I think when we were talking about this, I want to say that Pacific Source, maybe you had weighed in on this. Was that just in general, or was there something that you consider a short-term plan?
Hi, this is Jeanette Sims from Pacific Source. I'm assuming Mark Florian may have responded to that. And to be transparent from my perspective, nothing specific is coming to mind around short-term plans currently for Oregon policies anyways.
Yeah, that's a good, I should have probably clarified. It's possible that some of the carriers were talking about plans outside of Oregon. Any other payers have thoughts on this? Okay, we are going to go ahead then and include short-term health plans if any of them meet the data submission threshold in any future year. It does not look like currently that is the case, but we will close this question. Okay, next slide. So we wanted to talk about IBNR for claims. We talked about both claims and non-claims. So specifically talking about IBNR for claims. And we asked payers to send us a note after the March meeting about how complete your claims are at 180 days. We heard from a number of you, and you all reported that your claims are about 99% complete at that point, although the decimal point varied a little bit, but it's all very close to 100% complete. So our decision is to not require IBNR for claims. We think that is in line with what we heard from you last month about the level of administrative burden it would take to calculate that. And this felt like a juice not worth the squeeze to try to factor in less than 1% of the claims data and only have the actual paid claims. So we intend to include a % complete field on the data submission template for the completeness of the claims data, just so we can keep an eye on that. And if there's any payer in any given year where the data completeness drops below a certain threshold, probably looking for major drops here, not tiny nuance, we would potentially follow up and request IBNR or supplemental information just to make sure that the data continue to be comparable for trending. And it looks like, Drew, you have a question or comment.
I do. It's a question. Will the OHA then be, in essence, completing our data for us? Will they be taking that information and then increasing the aggregate or all the payments for the categories of service by 1%, for example? Or
no, no.
Okay.
I think it would be, it is what it is, and it would be stable over time. And so it would always just be 99% in the trend.
Okay. And then one last question. Just last meeting, we did briefly talk about should we do matched run out in the prior period? And I'm assuming this means now that we would not do matched run out, that we would have, in essence, infinite run, or not, whatever the, 2 years of run out in the base period data, or 3 years of run out in the base period data.
Yeah, I think the base period data will be a little different just because we're collecting it now. But in future, it would just be the 180 days.
Right. But there's no paid through criteria on the base period data.
I think
paid through current.
Correct. I think it's paid through current. Megan, can I call on you? There's no reason why we would want to limit that, right?
No, I don't think you want to limit the base period data, and hopefully over time this would be pretty stable, as you mentioned. Is there a reason why, I will just ask, is there a reason why you're asking this question? Is there something that maybe we're not considering that could potentially skew the baseline
No,
period to other periods?
There's no, I mean, the only reason I'm asking is because it came up in last meeting that we talked about, well, a way to get around IBNR inconsistencies or the inability to calculate IBNR at the categories and its intersections that's being asked was potentially do a match run out. But that sounds like this is not applicable
Yep.
given this decision.
Yep, I think your collective arguments last month about the value of IBNR for claims just were not, that was convincing. We are still talking about IBNR for non-claims, and we are still talking about what the right data submission period is to make sure that we're capturing sort of the full breadth of the data. That's not something we're bringing back today, but I think we'll talk about that more next month.
Hey, this is Bill Dwyer from MODA. I was just curious, on this slide here, when you're saying you'll include a % complete field, hopefully that's optional, because including % complete is exactly the same thing as requiring IBNR.
So I'm thinking about this. We asked payers last month to tell us generally how complete your claims are at 180 days. For those of you who responded to that, is that not something that you just track regularly and have a general sense of, or was it a specific calculation related to IBNR?
I think if it's an overall IBNR, we could probably provide that, speaking for regions. If it's by the categories listed, that would be challenging.
I think this would be overall.
Yeah, Providence would echo Jared's comments that overall, we have an easy table to look up to tell you at 180 days overall, how complete are we? And I assume that's what you're asking to be reported.
That is what I was thinking. I think we will need to be more clear about what we're asking for, but that is what I was thinking. Bill, does that address your concern at all, or is it still complicated?
That's fine. I'm not saying it's complicated. I'm just saying, you know.
It's not the same. Okay.
Yeah.
Okay. Other comments or questions about this? Okay, let's move on to the data submission updated specifications. Next slide. So we sent out an updated data submission guidance document, or updated specifications. We really have to land on the name. We did not send out an updated Excel template this month. We want to just do a final pass at the template to match where we land on the specifications. So there is no new template. All of the changes are in the specifications document. So I want to spend some time highlighting some of the changes we have made in the specifications, and then walk through some specific questions that we have for your feedback today, and then open it up to any broader feedback or other questions. Next, one more slide. Okay, so going into some of the changes that we made, all of the edits in the April 26th draft of the guidance are in track changes, so you can see that. And I really just wanted to recognize that not all of your feedback has been incorporated yet. Some of you sent really detailed feedback on the template and the specifications, and we have not worked through all of it. Some of it's incorporated, some of it isn't yet. If your feedback has not been addressed, that does not mean we are disregarding it. We have not worked all our way through everything yet. So thank you for that, and we'll continue to incorporate for next month. Okay, next, changes that we've made. This is a really high-level summary of some of the changes. It's not a line by line because that would have taken up the whole slide deck, but I just wanted to highlight a couple of things for you. So first bullet, we revised in the calculating performance against the cost growth target section to clarify that total medical expenditures are reported net of pharmacy rebates. The graphic that we had before and the way that we were talking about pharmacy rebates as a component was pretty confusing. And so we hope that this revision makes it more clear where everything sort of shakes out. We have also changed the denominator for total healthcare expenditures. It was originally the full Oregon population, and we've changed it now to the total population of everyone who is enrolled in plans. And this is based on some advice from our counterparts in Rhode Island, who realized that there was a really big difference in the population between the population and the enrolled population, and felt this would be a more accurate change. Megan, is there anything you would add to clarify that?
Nope.
Right, we added the decisions from the March tag that we already covered at the top of the meeting. We added a little bit more information about the net cost of private health insurance data source for self-insured and cleaned up the formulas a little bit in that section. We also revised the primary care taxonomy. So this probably still needs some more work in the submission, in the specifications, and we'll continue to iterate on this. We want to be clear that we're talking about primary care and primary care taxonomies in a couple of different ways, and that the taxonomy is different, or that there are different applications of it. So there is primary care attribution, a primary care based attribution method, and then there's primary care claims and services as a category for reporting the data. So we revised the taxonomy for the purposes of the attribution. We also cleaned that up a little bit. Several of you pointed out that we were including psych and OB-GYN in one place, but not the other. And we've revised that and been clear about what modifications we've made to the primary care spending report taxonomy that we are borrowing. Okay, we also added new sections that were not in the previous draft on mandatory reporters, the required lines of business for reporting, and the data submission process. All of that narrative is to align with the updated draft rules. So hopefully those two move in parallel. And a lot of that is process. So data would be submitted in this format by this date in this manner to this email address, as well as clarifying the excluded lines of business that we talked about last month. We've also added first drafts of the market enrollment section and the pharmacy rebate section, although flagging that for the pharmacy rebate section in particular, we still need to do a little bit of work to define the categories that we're looking for breakouts, specialty, generic, and non-specialty. I feel like I should stop talking for a second. Any questions about any of these changes? Okay, let's talk about some other updates that are in the document. So we talked last month a lot about the data submission timeline. We heard your concerns about the lift, especially in this first year for the initial data submission. And what we are proposing, or what we're moving forward with, is that the initial data submission, so that's the 2018, 19, and 20 data, will be due October 1st of this year, with an intent to have an initial data report in spring of next year. Then in future years, moving forward to that annual reporting cycle, we would move the data submission up a month. And we're proposing that the annual data submission would be due on the first Friday in September. And so that's September 1st of 2022. But it would not always be September 1st. So then we would have annual reports in the spring following that annual data submission. And next slide, just wanted to provide a little context, and I'll ask Megan to help with the details. But we looked at what it has taken other states in terms of when they submitted their baseline data and how long it took to get to that initial report publication, as well as what the annual submission period is and how much of a lag that is. So the top table is for the baseline data, and the second table is for the annual submission with the most current due dates dropped in. So you can see that 2 states have August submission dates and 2 states have September submission dates. So feeling like our proposed future date of September fits right in there. Megan, is there any other commentary that you'd like to share with us about the data submission process and timeline in other states?
Sure. I think I would just add that as states begin to work on this, there is a little bit of a learning curve, both from the state and from the payers. And I think there's actually a couple folks on the phone who have experienced that and can understand that the first cycle of reporting takes a little bit of extra time. And then as it becomes more routine, it can be an expected activity that happens annually, both for the payers and as well as the state. And so it becomes a more routine process. And that's very clearly been played out in Massachusetts, which has been collecting this data since 2013.
Are there any questions or comments about our proposed timeline? Michelle, can you go back one slide? And then Drew.
Yeah, sorry, I hope I don't come off like a curmudgeon. I have a question about the timeline and certain elements that are at least important in Oregon that are not, they're not settled by that date. For example, the statewide reinsurance program in the individual market doesn't settle by September of the following year. That's just one example. There are other not settlements that matter in total cost of care that just settle longer than that. And if we need to blow these, if we need to allocate these back down to provider groups, you know, to members to allocate to attributed member groups, and then using an accrual won't work either.
Yeah, Drew, thank you for that. I mean, I think as I referenced, we're still working through some of these details internally and don't have specific proposals or nuance. I think this was raised last month, possibly even the month before, and this is something we're working through. I don't know that we have a good answer yet. I think we're trying, and I'm sure I shared this last month, we're trying to balance between we need to actually have a line in which we collect data and then are able to publish, and then having that data be as complete as possible without waiting for it to be fully complete, which could take years in some cases. And how do we balance that? I think the direction we're leaning is, yes, there will likely be some things that are just not resolved or fully settled by this data submission date. And we will know that, and that will be consistent year over year. And so because we're comparing the trend year over year, it's always not reflected or it's always lagged. And we would handle it more that way rather than continuing to extend the timeline until every single payment or every single settlement could be made. But again, not fully landed on that, and welcome additional comments and feedback.
Sarah, I would just add to that, at least what we've seen in other states is that there is occasionally an opportunity to resubmit data or portions of data if the payer knows that there's a significant update in the information. For example, shared savings arrangements were settled, finalized in December, the year that the data were due. And if they were significant enough, it makes sense to update the data. And there's a lot of work that can be done with the data prior to all of those pieces being finalized. But I think it's an important point that you're bringing up, as well as what Sarah's bringing up, that there is a balance between waiting until we have everything finalized and actually, you know, working with data that we have and then potentially updating it later. One strategy other states use is they actually have a resubmission of prior year data so that you're always looking back and restating, in a sense, what that base is for the trend. And that is helpful in the sense where there are additional payments that are not settled by the September timeframe. And I know this is a challenge in particular for Medicare Advantage payers as well, because of some of the timing in which CMS produces data.
And
So
I would, sorry, just one more comment. I would say that we very early on with the implementation committee, and as we started thinking about the data submission process, we did look at the Massachusetts approach where they submit a preliminary and a final data file, and it's always sort of staggered. And so they publish preliminary results and then they update those results later. Our initial reaction to that was that that is not what we wanted to do. That causes a lot of confusion with the reporting, the messaging, the media, and understanding why numbers appear to be changing all over the place. And so we were trying to avoid that preliminary and final data submission approach, or data submission and reporting approach. I think the more that we talk about the specifications and the limitations, the more we're talking about maybe there needs to be the opportunity to submit the data in different ways. How we handle that on the reporting, communication, and accountability side is still an open question, and we would like this to be as straightforward as possible, knowing that this is a very complicated program.
So Sarah, will the OHA be a little bit prescriptive about those long tail items that are or are not to be included, like reinsurance recoveries, long settlements, Part D settlements or state reinsurance and settlements. I mean, I'm just asking, will this be prescriptive, or is this up to the carrier to determine it should or shouldn't be included in the base in the current period?
I'm not sure. I would love feedback on that. Would you prefer it to be prescriptive? Would it be more helpful if we tried to standardize that across payers?
There's value to consistency.
Yeah, I think in that case, we would need to understand, at least from all of the payers, what are the most common types of payments that lag, in addition to the ones that you mentioned. And then I think that would be, and also the value of those payments too, because sometimes what we're talking about when we've got all of this medical spending and you have maybe something small that doesn't get settled in time, it may not make a big impact. On the other hand, it could make a very big impact. And I think that would be helpful to understand as well.
The Oregon statewide reinsurance for the individual market is pretty substantial.
This is Jeanette from Pacific Source. It can be variable, but there have been situations where the Medicare sort of sweeps payments have lagged a material amount of time, like where it wouldn't fit into the timeline you are indicating. That's not consistently the case, but there have been situations. So having flexibility there when that happens would be helpful, because it can be material enough.
What about, and sorry, I'm spitballing now, this might make no sense, but if this was left up to the payers, would it make sense to just have a way to indicate that? Like, yes, these payments came in and they've been included in what we've reported this year, just so we would know whether or not a particular reinsurance payment or settlement was included. We could provide some categorization and you just kind of check off, yep, this is in this year.
Well, doesn't it have to be aligned with the base period and current period? I mean, you can't, right? If you can't, you need to be able to identify what, like, the payments need to be balanced in both periods, right?
Yeah, sorry, I'm trying to solve multiple problems at the same time here. I think your point about comparability of the base submission with the annual submission, in some ways, the base submission is going to be different, and we'll need to think about where we, not modify, that's the wrong word, but where we, how we handle the base submission to ensure comparability in ways that are helpful, but not necessarily that it will be identical.
I just want to make a point of clarification about the language that we're using. I think the base submission that Sarah's talking about is the initial data submission from 18 to 20. And then I think what Drew's talking about is the sort of the base of every year's change. Right. So I just wanted to make sure, because we're using the same terminology, I think, to mean different things.
So, like, for example, right now we know our 2018 and 2019 statewide individual market reinsurance recoveries. We don't know our 2020. And we know them at the member level. So if we don't know 2020, should we just exclude 18 and 19 also? And we won't know 2020 until like January of this coming year.
Yeah. I think I want to take this back to the internal team to, I guess, noodle on a little bit more. I think payers, if you have additional thoughts on what those specific payments are, what those specific categories might be, as well as the timing of them, it would be really helpful to get that from you over email, so that we can make sure we're sort of casting the right net if we're thinking about excluding anything specifically.
And just to be clear, we're predominantly talking about benefit expenses, not necessarily revenue. Is that accurate?
So revenue should be captured as part of the net cost of private health insurance through financial forms that you are completing, or, as Sarah mentioned at the outset, self-insured data come in a little bit differently. And so that's a different set. And we know that there is a lag issue with those data too. And so there's this balance between a consistent understanding of a lag, but I think there's less that can be done on that revenue side than there can be done on the expense side.
Or, I mean, right, so again, I get, should we be seeking balance, that if it's excluded in the, never mind, that's not necessarily the best way to put it, because I mean, revenue, benefit, expense aren't the same, but, all
I
right,
think your point is taken that we need to consider how we're handling the 18, 19, 20 submission, as well as if we're being specific about exclusions to address lagged payments or settlements. Yes?
yes,
Okay. We will report back on this in May. And again, payers, if you have comments on this, please email me. Your feedback is super helpful. Any other comments on the timeline before we move on? Okay, let's go to non-claims reporting categories. Thank you. So last month we had a discussion about several different options, several different levels of granularity for capturing or categorizing the non-claims payments. We heard some concerns from you that payers may not be able to separate out payments into exactly these categories. And we went back and forth between some granularity versus just a lump sum, all non-claims payments in one category. We agreed that we would not do a lump sum category, that there does need to be some categorization. And after some more discussion internally, we are deciding to align the non-claims payment categories with the Millbank categories. So on the next slide, you can see what those categories are. This is what was presented as, I think, option 3 in last month's draft. So there is some granularity, but it is, and there would be detailed descriptions of the types of payments that would be included in each. This is just the top line description. But we'd have capitation, global budget, case rates, and prospective episode-based payments, performance incentive payments, payments for population health and practice infrastructure, provider salaries, recovery, and other.
This is Jeanette Sims from Pacific Source. Can you clarify the usage around this, breaking this out, and how that will or will not align with the APAC submissions and roll-ups?
Yes.
Just so that we understand that.
I feel like I should probably just, we should probably just write up this answer because it's come up every time we've talked about non-claims reporting categories. So yes, we have non-claims information in the payment arrangement files that are submitted to the All Payer Claims database. Those come from payers. We are breaking out the data submission for the cost growth target with these non-claims reporting categories for a couple of reasons, because we can't get everything we need in APAC. Specifically, not all of the data submitters are the same. The cost growth target program has a broader net for data submission than the All Payer Claims data. And the payment arrangement files for APAC do not break it out at the provider organization level. So the big added value here is the breakout of these categories attributed to providers. And in terms of our intent for using this, this is not to track to VBP targets or anything like that. This would be to understand the trend of where the dollars are going and have some level of granularity of the categories and how that's shifting over time. Does that help, Jeanette?
Yes. So just to kind of expand, maybe I don't want to divert us, but when you say, you know, that the APAC structure doesn't isolate to providers, because I think it's at the contract level, and then these templates are at the individual provider level or PCP level, population level, is that the distinction that you're trying to make, if I'm following correctly?
Yeah, sorry, I shouldn't have said that the payment arrangement file doesn't have provider level breakout. It's that we want to have the same member level attribution of both the claims and the non-claims spend and have that assigned to the the provider organizations for the purposes of this program, which is different than the contract arrangements in APAC.
Okay. Oh, thank you. That I'm following.
Okay, cool. Drew.
I would just want trying to seek a little clarity about where a provider might have encounter data for a capitated service. Are we to, for example, where the service has been, let's say, outsourced, like behavioral health for maybe some carriers or lab, whatever it might be, we're to report the capitated amounts on a PMPM basis for each person in that PCP profile and not report the encounter data equivalent.
Oh, yes, if I track that correctly, Megan.
Are you talking about the capitation that a payer pays to a vendor? Or are you talking about capitation to a provider for a population of individuals?
I'm talking about I'm talking about a service that's been outsourced to a vendor. The vendor then makes those payments to the provider, but to the carrier, our payment is fixed at the capitated amount.
Right.
So
that is not what so that is not what should be submitted in this particular field. This is about capitated payments made directly to providers. So in the case that you carve something out to a vendor and you don't have access to that encounter data to estimate pricing, for example, then you would need to make an estimate, right? I'm sorry, Sarah, you're doing partial claims, right? So in the case that you don't have access to the data, you need to make an estimate of what that spending would be, recognizing that it's an estimate. If you do have access to the data, then you would submit the dollars paid from the vendor to the provider, not the dollars you pay the vendor to cover those services. Does that make sense?
it does make, I mean, I understand what you're saying. I have some concerns about that. I don't know if, I mean, I won't speak for any other carrier, but Providence doesn't necessarily always trust the data we get back from the vendor.
You can make an estimate on your own based on your own experience. I think that's okay too, if you have trust issues with the data that you're getting.
So why not just report the capitated amount?
Because the lens of focus for the cost growth benchmark is the spending from payers to providers. And what we are not, if we were to, let me think about this. If we were to capture the spending that you pay for a vendor service, we're capturing part of your admin as well as part of the medical expense spend, and then we would be duplicating that admin when your net cost of private health insurance is calculated.
I thought the goal was to calculate the trend. So, I mean.
Yeah, but we would be duplicating that in whatever portion of admin that is going toward that capitated service, right, would also be included. And so you're going to have, and that could vary over time, right? And so we don't want to duplicate the payments, even if we are, we can't guarantee that we'd be duplicating them the same way in order to track the trend over time. Does that make sense?
I'm not quite following that. This is Bill Dwyer again. Maybe I could just give a specific example. So let's say you have, for example, a mental health organization that's capitated, and you pay the mental health organization a fixed amount, and they take care of the mental health payments. It seems to me that if we're reporting our total medical cost, we're putting that entire capitated amount in there when we report what our medical cost is. Unless.
But part of that when you say mental health organization, is that a provider organization?
No.
Or an administrative services organization?
Yeah, an administrative services organization. I don't think when we would report what our medical cost is, at the level of like, what's our premium, how much of that premium did we spend on medical cost? I feel like we would put the entire capitated amount in there as a medical cost. Maybe I'm wrong about that, but I feel like that's what we would do.
So what you're saying is that in those financial forms that you report your premium revenue and your medical claims expense, that capitated service payments would end up all in medical expense?
You know, maybe
That's accurate.
Yeah.
That's how the NAIC reports it.
Okay. So let us take this back and noodle on this a little bit more before we finalize the answer to that question. If that's okay with you, Sarah.
Totally, that's what I was going to say. And I think this issue, which if I followed all of that correctly, this really isn't about these categories as categories. It's about where do we put capitation to additional or sub-capitation agreements and vendor payments. And if we come in and say you should put all of those vendor payments in this capitation bucket, or they should be reported separately, we would clarify that in the specifications. Are there other?
Can I ask one clarifying question about that topic? If you were to report capitated carved out services, would you be able to attribute those that spending down to the member level? And then, yeah, would you be able to send it to the
I
member
mean, I'm not going to speak for any other payer, but I mean, our cap amounts generally vary by line of business and they're a per capita basis. So we should be able to say Mary Jane is a member in Medicare and this is the cap rate for Medicare. And so therefore she carries with it that burden. You know, let's call it $12 per member per month. Whether or not she had that many encounters or not that's what it costs the health plan to provide behavioral health services for her.
Drew, you're saying you would essentially just add on the per capita cap rate to that member, not necessarily track their actual dollars.
So when you, I mean, it's
Yeah,
confusing
right.
when you call it actual. Like to me, the cap rate is the actual. That's what the liability is to the carrier. Dollars out of the carrier's bank account was the cap rate. I get Megan's comment that the dollars into the provider was whatever the vendor paid, but I don't have faith or trust in knowing what the vendor paid. And I mean, we could probably spend a year figuring out an allocation method.
Yeah, that's not knowable at the level of detail that you're alluding to there. I mean, you know, yeah, we would have to just allocate a fixed rate across all the population.
Which is what you would do if you didn't have access to the data anyway. You would estimate perhaps, I know at least in other states where pharmacies carved out, there's an estimate to say, well, in this fully, you know, when I have the full medical and pharmacy benefit for this population, this is the per capita figure on pharmacy. So I'm just going to apply it and assume. So, you know, at the end of the day, I'm not sure that we're talking about mathematically different actions at the end of the day. And so let us take this back and figure out what makes the most sense. But what I think I hear at least you two saying is that it would be easier maybe to report the capitated vendor payment amount and spread it across the population on an equal basis.
It would be easier. And Megan, quite honestly, I think it's also more accurate from a consumer perspective because that's the amount that gets ultimately reflected in premiums.
Right.
And this is Chris Hogan from Advanced Health. I would second the comments of Andrew and Bill. I think it's often not going to be feasible to track downstream medical expenses for subcontractors. Sometimes it might be convenient, but often we would just be allocating total cap dollars.
Okay, this is a helpful conversation.
Totally. All right, we will report back in May. Let's go.
This is Jared from Cambia. I had a question on the performance incentive payments. We have a few arrangements where a vendor manages those payments on our behalf. And I know it's been said that we shouldn't include payments made to a vendor, but would love to hear you comment on that particular circumstance.
Who is the, not who, but what type of vendor? Is it like a processing, or is it's part of like a subcapitation to a mental health organization and they also handle the incentive payments?
No, it's a way to facilitate rewarding providers for behaviors that would lead to improved quality or lower costs. And so they have different targets, they track those targets and make payments based on performance.
And you're saying you have a sort of a pass-through vendor that manages those payments?
Right.
I think the other perspective to think about that's not represented among this group is the provider perspective. So the provider, because they're also being held accountable to this, might say, right, yes, I got that incentive payment, but you're also allocating a couple of dollars to me because of these these vendor arrangements. And so I just want to be mindful of that perspective too. I don't think I certainly don't have a good answer for this example. This is an example I've never encountered before, but it's one that we should take back and consider.
Yeah, I think we need to think about like how vendor payments should be handled for each of these categories. But again, if there are specific scenarios that you all have that you want to send to us for consideration, that would be very helpful. Dean, you've got your hand up.
Yeah, I may have missed this in earlier conversations, but how are you suggesting that Part D for Medicare Advantage carriers be reported here? As many of the costs, obviously, in Part D are pass-through costs, and then there's a reconciliation process with CMS on the risk corridor side. And how are you suggesting that be handled?
I don't have a good answer off the top of my head. I will have to think about that. My sense would be that, and Megan, please correct me if you have a better answer, but isn't Part D a standalone drug plan and we're excluding those? No.
No, so Part D can be administered in a variety of different ways, and the Medicare Advantage carriers on the call might have standalone, might have Medicare Advantage prescription drug, there's a third option, I forget. At the end of the day, what the state will want is, the pharmacy spend for the Part D benefit, if it's part of the products that are being, data is being requested on. At the end of the day,
go
ahead, Dean.
So from a statutory accounting perspective, the reinsurance subsidy, the LIC subsidy are not really revenue sources. They are pass-through between the Medicare Advantage Part D benefit and CMS. And then, of course, there's the risk corridor, which I don't know how you would ever get a risk corridor down to the patient level other than just a straight up allocation, I guess. And that would certainly be a large, half the time, a negative entry. So, it's not, a lot of Part D is not generally in statutory accounting recognized as revenue, but the claims expense is certainly there. And, so a huge reconciliation process would need to occur to determine the rate of growth and the cost of growth, because it's really, the claims expense is there, but there's not revenue associated to it on statutory accounting basis.
And I'll also add to Dean's comment there, it's also variable from year to year. So it's not like if you say, if I exclude it in every year, you won't be balanced if you exclude the Part D settlement.
So I think we need to know a little bit more about Part D settlement specifically and the timing of that and how that can be applied. I will say that CMS provides states with Part D spending data. That does not mean that means the state still needs that Part D payment from the Medicare carriers that are reporting in the state, because the state is not going to get it on a carrier level basis, but on a population basis, they get the Part D spending.
And the settlement, Megan, just for your information, doesn't occur until the following November of the year. So a 2020 settlement wouldn't happen until November of 2021. And that's when all of that is settled up. So you may have an estimate by June, but you're not going to have the actual settlement that occurs.
And some of that is okay. I mean, I think there is a general acceptance that estimating some of the data, understanding what is being estimated and what is not being estimated is okay. And so I think that's part of this process too. I don't know how significant any of these are relative to the overall total medical expense.
Well, in Medicare Advantage plans, Part D, I mean, the claims expense for pharmacy is massive.
Sure, right.
So hugely impactful. But again, most of it's a pass through, and most of it isn't, really something that you would account for as revenue. So I don't know how you're going to deal with that if you're going to ask for the encounter data. How do you adjust for that isn't really related to revenue or any rate of growth?
I think we need to take this back and do some more digging. This is sort of a new problem to tackle. So thank you for flagging it. We will investigate. Drew, you have a question.
Definitely not as complicated as Part D, but on the performance incentive payments, can you remind us if there's guidance on if we can't allocate the performance incentive payments down to a specific patient level, how we're to handle that?
We don't currently have that drafted, but we can add it to the specifications. Yes, Megan, you're nodding.
In other states, there's flexibility with, in other states, in some cases, the state hasn't prescribed how to do so. And there's an understanding that if you can't do it, there's an equal allocation or spread across the individual members to the provider organization. So, it's up to Sarah and her team on whether they want to provide more specific guidance on how to do it, or whether there's general guidance with some suggestions.
I think based on the conversations we've had over the last 3 months, my sense is that this group would appreciate more guidance if we can provide it.
One other question I had is on pharmacy rebates. Is it the intention for us to put the rebates at a patient level?
Megan, can you?
No, the rebates can't be allocated, at least as far as we understand, down to the patient or the provider level. And my understanding is also that typically the rebates aren't shared at the provider level anyway. So it's really an aggregate rebate data at the market segment.
Okay, great. That's great. And then just so you know, the rebate run out is quite a bit longer than 6 months.
Yep. Okay, thanks.
Also on the rebate question, since that came up, one of the questions we had is some employer groups ask for portions of the rebates to be passed along to them. The rebates, are those just the rebates retained by the health plan, or how should those be tracked?
So can you repeat that? So you have commercial and you have employer accounts who have negotiated part of
the self-funded accounts, as an example.
So yeah, that should be reported. That should be reported. Let me.
I think we need to think about that one too. Yeah.
Great.
Because if we're focusing on dollars going to providers, those dollars are not going to providers, but we'll add that to the list of follow-up. Okay, let's move on. So, next slide, Michelle. We've got a couple of questions for you. These are things where you either asked a question previously, and as we were Working on it, we realized that we had questions about how it would actually operationalize, or where we borrowed some language from another state specifications and want to think about how it translates to Oregon. And in these cases, we are looking for your feedback. So next slide. First topic is parameters for risk adjustment methodology. So backstory context for this, the data payers will use their own risk adjustment methodology, and we are not going to require a single standardized risk adjuster across all of the data submissions. We will ask for details about what risk adjustment tool and version was used, but we also wanted to provide some guidance about parameters for risk adjustment and just some general principles to be followed, or making sure that whatever software tools are being applied follow this guidance. So these are the proposed draft parameters for your feedback. And they are, where possible, payers should use the following parameters. The risk adjustment tool used should correspond to the insurance category reported, so not using a risk adjustment for the commercial population or vice versa. The risk score value should reflect Oregon residents that are included at the payer and provider organization levels, so you shouldn't be excluding residents from the risk adjustment. The scores should be rebased or normalized for every data submission to ensure accurate comparison of trend across years. This one, put a pin in, because this relates to our, do we submit 1 year of data, 2 years of data? How do we handle some of that lagged information? So yes, we want to do some rebasing, but also noting that there's a tie to that broader conversation we were having. Payers should use concurrent modeling rather than prospective. So based on services a patient has incurred, not based on any projections. And then finally, health risk scores shouldn't be adjusted using price or costs. They should only be demographic or condition focused, and nor should any data be truncated. So no excluding outliers. Do you have questions, feedback? Do these parameters make sense? Are there other parameters that might make sense? What do you think?
This is Jared. The question I had was on the normalized piece and what you meant by that. It sounds like we would come back to that. The only comment I would make is, in some of our populations, aging is a consideration. And so as the population gets older, if you're normalizing out the risk scores, you're sort of removing the impact of aging and recognizing that populations get more costly as they get older. So I wouldn't want to normalize out those types of real differences.
Great point. Thank you.
So can I just push back on that a little bit, though, to ask, does the age adjustment really matter in a year-over-year trend, right? Because the measurement is going to be performance year compared to previous year, not like 2020 and then sort of rolling, always looking back to 2020. So does 1 year really make a difference?
Well, I mean, as you look at demographics, 1 year of difference means the costs will be just that much higher. And when you have a 3% target, it's already, it could make a difference between meeting or not meeting the target. Yeah.
An average of 1 year aging is worth about 1/3 of a point.
Say that again, Drew. On average, 1 year of population aging is?
I mean, depends on the population. It's not even growth, but in commercial population, 1 year is worth about 1/3 of a percentage point in trend.
So we're talking about 1/3 of a percentage point overall, right? Because if every year it's renormalized to that, every year it would be 1/3. Is what I think I hear you saying, is that every year 1/3 of it is due to the fact that the population aged from 1 year to the next.
I
don't think it's as simple as that. Sorry, Jared.
No, I think we were saying exactly the same thing.
It's not as simple as that, Megan. I mean, there's other churn that needs to be accounted for. I mean, I agree with Jared that I get that you'd want to renormalize if we changed risk score methodologies, but or risk score models, But if we're using the same risk score model, why not just report the risk score as is?
So what I think what we're trying to do is that every time OHA, excuse me, calculates the trend from one year to the next, one needs to be the same thing in the first year and the second year. And so every time that calculation happens, the first
Okay.
year, right?
Right. Okay. I understand that. I think that then we're all, I think we might actually, at least you and I might be on the same page. If all else being equal, year one would be equal to a 1.0 and year two would be equal to a 1.003. But as long as the 2 years are on the same model,
Yes.
Yes.
then we're capturing what we need to capture.
Yes. Yes. So if that's not clear in that third bullet, I think we would welcome language to make that clearer.
This is Jeanette from Pacific Source. I'm maybe a little bit confused, but the way I'm reading the third bullet is that we're rebasing the population every year as a 1. So I think, and I don't think that's the intent because you're trying to capture how the risk is changing over time. So I think perhaps some further clarity that sort of illustrates, like to Drew's point of, if we're using the same model and it's essentially, even if baseline year is not a 1.0, if we're using the same model and the risk is shifting over time, then it should capture that change in risk over time, if that makes sense. But I think it reads like you're asking us to rebase the population as a 1.0 every year, just to clarify.
Right. Yes, understood.
Okay. We will modify that. And yes, if anyone has a better way to say that, feedback welcome. Other comments about the risk adjustment parameters? Okay, let's go to the next question then. Next slide, please, Michelle. So starting to get back to our conversation about the length of time to reconcile payments and when settlements happen and all of that good stuff. Megan shared with us that one option would be to actually have a separate reporting period for the non-claims data. That would allow for additional lag. And I don't know that we want to decide today, but I think we wanted to hear from you about the pros and cons of having a separate data submission for non-claims. I think in some ways, yes, more complete data might be a little cleaner in terms of the inclusion exclusion criteria we were talking about, but also administrative burden in having a separate submission and trying to manage everything in 2 separate processes seems like it could be complicated. Megan, is there anything else you would add before we open it up?
No, I think this just gets at the idea that there are a number of payments that have significant lag that you've mentioned already. And so we're just trying to get some better guidance here.
What do you all think about a separate reporting period, which would be on a later timeline than for the non-claims?
Hi, this is Tracy from CVS Health. We would rather, I think, do the adjustment or the estimating for what we think may be paid out later than to actually do a separate reporting period, I think, for the non-claims.
Okay, thanks.
This is Anna from United. I just want to say that it would be a burden for us to do a separate submission for non-claims. So if we could do it at the same time, that would be great.
Thank you. Drew?
I see the benefit in doing it all at the same time, although I have concern about the accuracy of estimating at a patient level, and therefore being able to allocate back to assigned and attributed providers. And so like things like reinsurance recoveries, which have long tails on them also. I assume we'd want that at a patient level.
So all the patient level data gets rolled up into the provider level. And so I think it's okay that you don't have some of this at the patient level. If you just,
I mean, I don't think that's true, Megan. Like, we might have some providers that tend to attract a more sick population are going to have a disproportionate share of reinsurance recoveries. I need to know that with a better degree of precision than I think we'd want to know that with a better degree of precision than saying, well, we expect $6 million of recoveries and, divided by X number of patients. That might hurt Providence or OHSU and benefit, or the other way around, actually might hurt a provider who doesn't tends to have a healthy population. We're suddenly allocating, cost to them.
yeah, so you don't have that information at the provider level to start with, is what you're saying.
Not if we're estimating it, right? I mean,
okay. So I think, Drew, not to cut you off, because I totally recognize this is the open challenge of how we're handling all of these different non-claims payments. But what I heard you say initially was that you see the benefit of a single submission. You just have concerns about the methods. Yes.
Yeah. I mean, if I were king for a day, I'd say, let's just move the whole single submission out to later.
Yes, I'm sure a number of other payer comments, perspectives on a separate reporting period or a single submission.
So this is Jared. From my perspective, I don't know that we have strong opinions if it's an estimate or wait till we have actual data. It would be helpful if there's, consistency or any sort of accounting standards we should be following or numbers that we're already filing. Just trying to think of a way to make sure that there's consistency in how things are approached, but no strong preference, I think.
Okay, thank you. Anyone else? Okay, we will keep thinking about this whole non-claims conversation and come back to it in May. Next slide. So as we were drafting the specifications, we wanted to provide a little bit of clarity. We had some conversations, and one flag was that there might be some trickiness for payers in reporting members if they change from one line of business to another during a calendar year. I do want to clarify that in this month's version of the specs and moving forward, we've switched to member months. We had not been using member months before. We had been just using total count of members, but we have been convinced we are going to member month reporting. And so we don't think that tracking members who might change from one line of business to another will be a problem because of the member months. You should be able to just allocate members to the line of business for those months and report the medical expenditure data exclusively, mutually exclusively. But we just wanted to double check that assumption that you wouldn't have any problems with allocating members if they change lines of business within your book of business. Any concerns? I'm not hearing any concerns. This is great.
Sorry, I'm just making sure. This is Jeanette from Pacific Source. Are you saying that we would essentially, when a member switches line of business, we're reporting their information for one line of business while they're on that line of business, and then reporting separately that member's information on another line of business when they're on the other line of business?
I think we're saying the same thing. Let me.
Okay. That we're not trying to combine their
no
experience or anything. Okay.
No.
Yeah.
And you would separate their expenses. So if someone moved from Medicare to commercial, or commercial to Medicare, or Medicaid to commercial, you would report their Medicaid expenditures during their Medicaid enrollment on the Medicaid line and their commercial expenditures during their commercial enrollment on the commercial line. You wouldn't duplicate the reporting in both places.
Thanks for clarifying. That's how we would report it. Yes.
Yeah, this felt pretty standard once we actually spelled it out, but we just wanted to double check. Okay, I'm going to take your silence as agreement on this one and move on to our next question. So as we were talking about the claims payment categories, next slide, please, Michelle. Megan noted that Massachusetts has begun collecting behavioral health expenditures as a separate service category. And so we wanted to talk to you about what you thought the value would be, pros and cons of adding behavioral health as a category. And there are two ways we could do that. On the slide, it just says professional behavioral health providers, which would be sort of the provider-centric outpatient behavioral health, or we could do behavioral health all expenditures, which would include hospitalization, ED, and other services. My perspective, obviously, I would love the option to be able to look at behavioral health trends separately. I think there's a lot of value in that, but wanted to hear from you about pros and cons of doing that. The lift in breaking that out, we would of course provide definitions of what should go in what category, but thoughts about the value add of breaking out behavioral health. I think I saw a thumbs up from a couple folks. Anyone have major concerns about this? Or minor concerns, that's okay too. Okay, I'm going to translate your silence as agreement. So let me ask about preferences. Does it make more sense to you to, nope, sorry, Michelle. Does it make more sense to do behavioral health all expenditures or to focus on the behavioral health providers as a professional service category?
So
I think there could be a little ambiguity between some of the categories. You'd get a little, if you did it at behavioral health all, you'd probably smooth out some of the potential inconsistencies.
Can you say more about that? I'm not sure I followed.
Well, maybe like what one provider or one carrier calls outpatient might look like professional in like another carrier or another provider. And so, this can be small ambiguities in categorization.
Megan, were you going to clarify? Or
well, to Drew's point, this is going to need specific definition around it. What I was going to add, though, is I think to Sarah's question, when you look at behavioral health as an overall category, that crosses multiple of the other service categories, which I think maybe, Drew, what you're talking about. For example, there's inpatient spending, there's pharmacy spending, there is probably outpatient spending at residential facilities, et cetera. And so I think the question is, do you want to look at behavioral health as that whole, which I will say will have its own sort of need for reporting spec, or just look at the professional services. So we have professional primary care, we have specialty, and we have other. And what we probably would be doing is taking that sort of specialty and other and taking out behavioral health providers and just sort of putting them in their own bucket. So I think those are the two options.
And I think, I guess now that I'm talking about this more, it feels like if we went in the direction of behavioral health all, it would need to not be a mutually exclusive category. It would be a sort of both and category, because we'd still want to know the pharmacy breakout within behavioral health, right? We wouldn't want that to be, we wouldn't want to not have the ability to see what the behavioral health pharmacy spend was. So either we create a whole new set of categories that are more granular for behavioral health, or it's reported in both places. Does that make sense?
I would advise against reporting it in both places. That seems like it could lead to problems.
This is Jeanette from Pacific Source. I would also recommend we don't try to report it in multiple places because I think it will create confusion. And it is, I mean, depending on the scope of what you're including in behavioral health, because there can be kind of a broad category of services like MAT services, for example, really generally categorized as therapeutic injections. But if you are sort of encompassing them under this as just an example of the complexity that could be involved in sort of maintaining and supporting a definition around behavioral health, I think it is probably one of the areas that could have maybe the most sort of diversity in billing practices amongst the entire service array. And so that maintenance will be, if you're going to give us sort of consistent definitions, will require pretty detailed guidance, and will have to be pretty well maintained over time. And because I know, for example, in Medicaid, there are some sort of coding differences, for example, that you might not really generally see in commercial. So just to kind of give you that perspective to think about that.
Thanks, Jeanette. That's really helpful. And so given that, and given advising against reporting it in both places, does it seem like adding the professional behavioral health provider category makes more sense than trying to capture behavioral health all?
The Providence might have some difficulty breaking it out for the period where we had outsourced this to a different vendor. Where we had it outsourced. So I'm worried about our ability to accurately, I mean, we have cap payments that cover behavioral health all while it was outsourced.
Yeah, I would wonder too about other payers who carve behavioral health out, and to what level they could actually be able to accurately report this, even if they're estimated data. I mean, do you have insight into that? Like, if you're paying a cap payment, but you don't know how much of, do you know how much of that goes to, ED observation?
I know it is. I mean, we know it at the aggregate level, but we wouldn't be able to be precise about the provider out, the patient level, and therefore at the provider allocation approach.
Other commercial payers, Tracy, Anna, do you have thoughts on this one?
Well, I just want to add, so Massachusetts, we do a separate filing for behavioral health, but they provide us code lists and the coding logic. So that's something that we definitely would need. We wouldn't just be able to bucket this based on our judgment.
Yep, totally.
Right, and that's the same for Aetna. And I think we do report it as a subset of, I'm thinking of the member months actually. We report the behavioral health member months as a subset of the total member months. But yeah, we just started that last year. I'm not sure how useful they've found that reporting.
So one other consideration, which I think, Tracy, you're just speaking to, is maybe we don't launch with this. Maybe we incorporate this in a future year. This is something we come back to. And I think I'm really struggling with that personally, because I think adding things and sort of revising the process down the road is more difficult, especially if we're adding whole new categories. And I think we've heard from you previously that you'd prefer that we don't, drastically change the template and the reporting plan every year. And so thoughts about maybe holding off on breaking out behavioral health for a couple years until we get our feet under us and maybe we understand more about Massachusetts experience?
I would be curious to see how much value Massachusetts found and the way that they were doing it and what they were getting.
Other
I
thoughts?
think too, if once you get into like breaking out more and more categories, like I know one of the states we report for does like specialty primary health, and then capitation primary care versus regular capitation. The report gets pretty lengthy too. Something to think about.
Other comments? Okay, if you have additional thoughts about behavioral health data, behavioral health breakouts, again, please send us an email and we'll keep thinking about this. All right, next slide. My last question for you today. So again, with the claims payment service categories, we have an other category currently in the template. When we were drafting the specifications, we were like, well, what actually goes into this other category? And we realized that we were including it because we were aligning with other state templates. So other states have some specific lines of business and services that they want put in that category. We do not have those scenarios. We don't anticipate any data being reported in this category. And so we wanted to ask you, especially those of you who report cost growth data from multiple states, would you prefer that we leave the placeholder so that the Oregon code might line up more with other code, or just delete because we don't anticipate anything being in this category?
This is Tracy from Aetna. I think that it does. We like the idea of keeping the template pretty much the same as far as the same bucketing categories. But also I think that this is a good, I want to say, test, so that if there's something that falls through all the other categories, we can kind of see that that's something that maybe we need to take a look at and bucket it somewhere else. Just a thought.
Having it as an overflow, basically.
Right.
This is Anna. I think we always have something in here, and I'm thinking maybe DME might end up in here.
Sarah, are we talking about claims payments other, or are we talking about the other?
Oh my God, did I totally put the wrong? Is this this is the market, not claims payment?
Yeah, sorry.
No, my fault. I'm so sorry. Megan, please restate the question.
Okay, so in the other state templates, when you're reporting by line of business, you report Medicare, Medicaid, commercial, commercial partial, and then now some states are separating out the dual products to the extent that some payers have those. And there's always been the other, and I think that happened for Massachusetts because they had a couple of sort of unique health plan products or lines of business, for lack of a better term. And I think what Sarah is meaning to ask is it helpful to include that other, or should we delete it? As opposed to the claims, which we do expect there to be others.
Yes,
and I think
totally.
Anna, DME is a great example.
I might have, this is Jeanette from Pacific Source. I might have missed this in the documentation, so I apologize. But can you clarify what category Cover All Kids falls under?
Medicaid.
Since it's not a Medicaid program, technically, I think.
Medicaid.
Okay, so you're including it in Medicaid? Okay.
Yeah, and we need to clarify, like Cover All Kids, CHIP, all of that would be within the Medicaid bucket.
Do you, oh man, then you'd also then need to include the settlement from the OHA back to the CCOs for Cover All Kid, because it's, I mean, it should always just come out to be within, the risk corridor range. Seems like we're creating something that's harder to do than necessary with Cover All Kids.
Maybe we need to take Cover All Kids offline for some more discussion about the settlement. I was thinking that it was essentially just the same in terms of capitation, but let's talk more. Okay, so sorry, back to the question, which is totally wrong on the slide. Should we leave a placeholder in the template for an other line of business or other market category? So Medicaid, Medicare, commercial, other, knowing that we don't expect to use it in Oregon.
I would say remove it. We don't expect to use it in Oregon.
Okay, there's no value for you in keeping the additional category for cross-state efficiencies.
No, not at all.
Okay. Great, that's easy then. Well, we will remove it. Okay, and next, I think we just wanted to leave a little bit of open time if folks had any additional questions that we may or may not be able to answer today, or other things that you'd like to flag for us to keep working on. I also know that I only sent out the updated specification document on Monday night, and you probably have not memorized all of the changes yet. So apologies for the late notice on that, and feel free to send questions over email anytime between now and the next meeting as you dig through that. Jeff.
Hi, thanks, Sarah. This is Jeff Winkley from the Association of Oregon Association of Hospitals and Health Systems. Just one thing. Wondering, I noticed on the guidance draft that the validation piece is kind of to be developed. We're just wondering, what are the validation and verification steps? I think from the provider perspective, involvement on our part, we would see would be kind of key to this, since we are, as Megan mentioned earlier in the discussion, part of the accountability of this whole effort. So
Totally.
that piece of it.
Jeff, that's a great question. Thank you for that. In the data submission document, that validation placeholder is focused on the validation of the payer submitted data. And it's on my list to bring back to this group, probably starting in June. I think we'll need next month to finish really talking about the specifications and the template, and then we'll move into validation. And I want to make sure that we have a clear validation plan for what are the steps, both automated validation checks and more nuanced, that we will apply to the payer data submission. Once we have that pinned down, hopefully this summer, then we'll talk about the provider validation and what the data sharing process back to the providers and the opportunities there look like. Because the provider data will be generated from those payer data submissions. So we want to make sure that we've correctly validated the payer data at the payer level before we move to the provider. So coming later this year, does that help?
That does, definitely. Thank you.
Great. Other questions, comments from anyone? All right, then I think we will go ahead and wrap up a little bit early. Michelle, last slide, please. Our next meeting is Wednesday, May 25th, 6th. I can't read my screen, it's too tiny. Whatever the Wednesday is in May. Same time, we will have another update of the specifications document and probably the template at that point. We will come back to these questions that we flagged that need additional discussion. Again, if you have feedback about anything we've talked about today or about the draft specifications itself, particularly if there's anything in there in our new text that's confusing or you're not sure how to interpret it, please let us know that. I think knowing where there's potential room for misinterpretation or competing interpretations would be really helpful in guiding us where we need to provide more clarity and maybe more examples. And then finally, you do have the draft temporary rules. So please let us know if you have any feedback on the rules in the next week or so. We're hoping to move forward with getting the temporary rules filed in May so that we are all set for the data submission October 1st. But again, just wanted to make sure that you had an opportunity to review and provide feedback on that. Any closing questions or comments from anyone?
Sarah, this is Jim from Advanced Healthcare. Quick question. I think a couple meetings ago, you had indicated the CCOs would be getting further guidance about the templates and the structures and things that they need. Is there going to be a different template structure that the CCOs are going to use, or are we expected to use everything that you're striving for here?
CCOs will use everything. There'll be a single template that CCOs will also use. That said, Jim, you might notice in the specs, there are a couple places where we've got some placeholders where we need to clarify things specifically for CCOs. So for example, how do CCOs handle dental? How do CCOs handle health-related services? So we expect that all to be resubmitted in the same template, but we'll provide specific instruction.
Okay, so that'll be coming in the next month or two, or you'll be bringing
We're
that
working
up?
on it. Yeah.
Yeah.
Hopefully we'll incorporate that in the next draft, but
Not trying to impose any added stress in there, but just want to make sure we keep aligned with what's going on, that's all.
yeah, totally. And we're trying to pull all of the CCOs into this technical group. We'll report back out to like the CCO Ops Collaborative and maybe some other venues, but this is the primary venue.
Perfect, thank you.
All right. Thank you so much, everyone, for your time and your participation and all of your very helpful feedback and good questions. I really appreciate it and look forward to continuing to iterate. Have a great Wednesday.
Thank you.
Thank you.
Thank you.